Fitzgerald, are you ready?
I am. Good morning, everybody.
Okay, great. It's my pleasure to introduce you to the group today. And it's the first time I've gotten a chance to meet you myself. We've just been emailing a little bit. So anyway, I'm going to read a little bit of your bio so everybody knows about you. And we're looking forward to your presentation. Dr. Brendon Fitzgerald is a clinical audiologist at the University of Rochester Medical Center here in Rochester. He completed his Doctor of Audiology degree from the State University of New York at Buffalo in 2020 with an externship at the Cleveland Clinic in 2019 to 20. His clinical and research interests include tinnitus, hearing protection, and hearing loss prevention, particularly in musicians. As a doctoral student, he organized and presented the University at Buffalo Hearing Health Lecture Series and provided care to patients in the Cleveland Clinic Tinnitus Management Clinic. Brendon holds a Master of Music degree in conducting performance from the State University of New York at Buffalo, graduating in 2011. Before his career in audiology, he taught music in public and private schools and presented workshops in improvisation, composition, and performance at high schools and universities throughout the Northeastern United States. He currently serves as director of the contemporary chamber music ensemble called Wooden Cities, based in Buffalo, New York. So we've got quite a variety in your background, and we're very happy to have you join us today and present. So we'll welcome Dr. Brendon Fitzgerald.
Thank you so much for such a kind and warm welcome. Give me just one moment while I pull up my presentation here. And I'll give sort of a disclaimer that, we cover a lot of ground in this talk today. But hopefully it just kind of gives us an introduction into some of these topics and some different ways to think about music appreciation and that sort of thing. Can everyone see my title slide here, Music Listening, Tinnitus, and Hearing? Can everyone see that title slide?
Yeah, Brendon, this is Chaz. I can see it just fine at my end.
Excellent.
Yes, I can.
Yeah, we're seeing it.
Excellent. Thanks so much, everybody. And so very quickly, we'll talk briefly about the audiogram today, but maybe not in a way that you're kind of typically used to. We'll talk a little bit about how sound and frequencies work for music and what the audiogram can do for us. We'll talk a little bit about tinnitus, what it is, where it comes from, and some updates in tinnitus management. And then we'll also talk about various hearing technologies, hearing aids, cochlear implants, those sorts of things. And lastly, we'll kind of round it out with some ideas about how we can maybe better access and appreciate music, which, as we'll learn, is a very individual process for everyone. It sounds like a lot of folks are very familiar with the audiogram. Basically, it's a tool that us audiologists use to map the quietest sounds that a person can perceive. And I've got a little asterisk there because really what so much of our testing in audiology focuses on is speech understanding. And so it's not terribly important, but if you can see that shaded region on our audiogram here, we call it the speech banana. Essentially, it tells us where certain speech sounds lie in terms of both their pitch or their frequency and their loudness. And this is important to our discussion in a little bit. I know a lot of you have probably seen various graphs and representations of your hearing levels. But we'll talk about kind of what this means for music listening in just a little while. We'll come back maybe to some trivia later. If you know the answer to the frequency range of human hearing, then you get some bonus points today. But really the question, what does the audiogram measure, is really that we're trying to measure speech perception. That is typically what the audiogram is used for. So if we look at my mapping of some frequency ranges or pitch ranges of some various instruments here, we'll start at the top, our piano there. You can see that I've got a little black bar starting around middle C. And that's around 250 hertz, which is where we start testing for our audiogram, our speech understanding. And it goes out to about 8,000 hertz. And you think, wow, that seems really, really high. Especially because if we look at all of our instruments below that, gosh, it doesn't even look like those ranges are very much outside of 4,000 hertz. So we should be able to hear all of those instruments perfectly well. But really, what this slide illustrates is that instruments, just like our voices have their own unique characteristics that make them sound like us, instruments are made up of more frequencies than is just represented on this chart. They have what's called harmonics and partials, and all those kind of in-between frequencies are what makes a cello sound like a cello and a trumpet sound like a trumpet. They can all play the same note, maybe a middle C, but they sound different because of typically some higher frequency information that comes to us. And again, this is setting us up for some important information later. I am regularly seeing patients and individuals who their primary concern is tinnitus. And it is very difficult for us as audiologists to move forward discussing tinnitus without further evaluation, seeing if there are any things that might help explain what's going on with that patient. So we'll talk a little bit about how tinnitus is, some of the theories behind the causes of tinnitus, which is always a very hot topic. And we'll also talk about some of the management strategies. So when we talk about some of the causes of tinnitus, it can be caused literally by hundreds of different things. And quite often it's more than just one thing at a time. Quite often, many of the individuals that I see regarding their primary concern being tinnitus also have some degree of reduced hearing levels. There could also be other things going on, including infections, head and neck trauma or tension, inner ear disease, even things like diabetes, TMJ dysfunction, things that you wouldn't necessarily think this is related to my ear can also influence our ears in perceiving this ringing, rushing, roaring, however you experience your tinnitus. So, we think about tinnitus as it's initially caused by some outside thing, and quite often more than one thing. That's important to remember. What's most important, though, is to think that we really do need a quality evaluation, either from your MD or ENT or us audiologists, or really that whole team, to kind of help look at what's going on. This all looks very complex and complicated, but at the end of the day, if you look at this picture of our brain here, they've done some studies. This was what they call a meta-analysis, where they take a whole bunch of studies and kind of break them down. And these studies we're trying to map in the brain where they can find activities of tinnitus. And initially, they thought it was just in what's called the auditory cortex, which is just kind of a place where sound seems to be delivered. But over the years, the more studies they did, they started finding that it's really kind of a very, very complex thing. It's very difficult to map in individuals. So while we see all these various shaded regions lighting up in tinnitus patients differently than those without tinnitus, it doesn't necessarily mean that all those areas are lighting up, or that it could be kind of widely varied across a population. But this gives us an idea that it's pretty complex. So what can be done for tinnitus? Obviously, when there are things that can be done in a medical way to address tinnitus, if we think about, for example, I have seen patients with wax in their ears that can kind of contribute to their tinnitus, or if a medication is causing it, maybe there could be ways to consider if a different medication is possible, or how can we manage that TMJ dysfunction. And obviously that's the first step. That's why you see a team to see if there's anything that can be done to address obvious causes. This does not necessarily mean that if those causes are found and addressed, that tinnitus necessarily goes away, because we know that it's more than just what happens in our ears. We know that it's a brain level thing too. I get this question all the time. Is there a pill for tinnitus? There's been lots and lots of efforts to try to find that magic pill, and to date, there really isn't anything that specifically is intended to treat tinnitus. When we move to, after considering ways to manage that peripheral problem, whether it's the ears or the jaw or head and neck tension, audiologists, we tend to start thinking about what are the other causes? And quite often, tinnitus is only a problem when it becomes bothersome. So when we talk about tinnitus management, we're actually beginning to talk about not just how we manage medically this condition, but how we also manage how bothered people become by this perception of sound. So there's been a lot of studies that indicate the more bothered we become by our tinnitus, the worse it can get, which is unfortunate because it's a bit of a feedback loop. So a lot of these other kinds of management strategies are intended to help also manage an emotional component, to help sort of decouple the brain from doing the thing that it does that makes that tinnitus bothersome. So one of the obvious ways that we can help address tinnitus, I initially said that it can be caused by hearing loss. And so one of the theories behind that is that when someone has hearing loss, the brain is not getting sound stimulation. And a reasonable way to present that information back to the brain is through various amplification, right? So hearing aids are the obvious thing that can do that at sort of a prescription level. Or similarly, bone-anchored implants, cochlear implants. The intention there is to provide the brain with stimulation again. And then the brain says, oh, okay, well, I guess I can turn that sound off a little bit. I make no promises to patients when we start down this road because every brain is different. And like I said, it's very, very complicated. So this comes to us from the American Tinnitus Association, which is really the only place on the web that I recommend to my patients because there's a lot of scary stuff out there when it comes to tinnitus information, because there really is, to be quite honest, a very robust market for folks to take advantage of people who are suffering from tinnitus, whether that's from something that you stick in your ear or a supplement that hasn't been discussed with your doctor or those kinds of things. There's a lot of misinformation on the web. So I always try to steer folks in the right direction when it comes to tinnitus information and management. So from the American Tinnitus Association, these are some of the theories behind how we can help provide some stimulation to the brain, but they also, these amplification strategies also do some other things. So with this masking strategy, I never recommend that we completely try to cover our tinnitus, because ultimately, when that sound that we use to cover up our tinnitus is gone, a lot of patients tell me their tinnitus is that much more bothersome again. So typically I'm recommending that we're presenting some kind of sound stimulation. It could be either through speakers or hearing aids or sound amplifiers, Bluetooth headphones. But the goal here is to give the brain some stimulation, and also bring the ear's attention away from that bothersome tinnitus. And that's what we see in our distraction technique, right? So we said the more that we spend time listening to and focusing on our tinnitus, sometimes the worse it gets. So just by having some sound stimulation in the background, that can help kind of draw that ear's attention away from it. Habituation is another idea that essentially we're trying to retrain the brain to stop listening to the tinnitus in a sort of alerting way. And that can be kind of difficult to experience or describe to tinnitus patients, because it's almost like when we check in on our tinnitus, then we're thinking about it. So it can be challenging to describe this effort of habituation of, yes, I hear my tinnitus, no, it doesn't bother me. That's a major challenge for many of my patients. The idea of neuromodulation has somewhat fallen to the wayside in recent years because there really wasn't too much evidence to support that a special sound can help minimize this neural hyperactivity, the brain level activity that is thought to be tinnitus. So back in the 90s and early 2000s, there were some special efforts to try to use these very specific sounds to help kind of rewire the brain. And not to say that those devices weren't effective, but that they've now kind of found that tinnitus, really when we use almost any sound that we find pleasant or relaxing, or that provides any of these kinds of strategies, whether masking, distraction, or habituation, can help sort of draw the ear's attention away and sort of reduce tinnitus bother. So it can really be any sound. Some of my patients tell me, I love nature sounds. It makes me feel relaxed. Well, we also know that emotional component of tinnitus is a very real one. It actually does reinforce our tinnitus. So when we feel more relaxed and maybe a little distracted, and we're covering up that tinnitus a little bit with our nice nature sounds, we'll see patients reporting a little bit of relief from their tinnitus. Something that's been most surprising to many of my tinnitus patients is that we've discussed now that tinnitus is not just an ear level thing, but a brain level thing and an emotional level thing. And so when we look at some of the latest management strategies, we see that these are essentially kinds of behavioral therapies, right? Cognitive behavioral therapy, mindfulness-based stress reduction, typically coming in the form of mindfulness practice or meditation practice. Tinnitus retraining therapy and progressive tinnitus management. These are all really therapies that are intended to manage our emotional reactions and responses to tinnitus. And it's important that we let that sink in for a little bit, because when we talk about tinnitus management, we rarely are talking about curing tinnitus, or rather getting rid of that sound. But the more we are able to manage emotional reactions and responses to tinnitus, the less bothersome it becomes. And over time, the goal is to have individuals with tinnitus feel like, well, yeah, it's there, but I don't really care about it. That can be quite a long road to travel for many tinnitus patients. And that's why I think it's really important that, you know, at the end of the day, you do have a quality assessment from folks who are trained in tinnitus. I'm very lucky to be working at the U of R because we've got some really wonderful clinicians here, both in ENT, primary care, and here in my audiology department. And so when we look at the picture, the whole picture of tinnitus, obviously we're going to try to manage anything that may initially kind of deprive the brain of the sound that we need to hear, whether it's an infection or hearing loss or those kinds of things. And then manage some of those emotional reactions and responses to our tinnitus. A few years back, we became somewhat curious about tinnitus, and particularly in the context of meditation. And when we began to look at some of the studies that map meditation patterns onto the brain, and what areas in the brain that meditation also impacts, we saw a lot of overlap. So an idea came about. Could tinnitus potentially help remap some of those problems in the brain? I'm sorry, could meditation help remap some of those areas that are affected by tinnitus? And we didn't do any imaging with this study, but we'll start to see that these areas where tinnitus and meditation overlap, there's quite a few of them. So the thought was, well, we may not be able to know exactly what's going on in each brain, but what if we just had folks try meditating and see if it helps their tinnitus? And again, meditation is an effort to help learn how to control, manage our emotional reactions and responses to our tinnitus. So what we did was we found 15 willing subjects who reported their tinnitus as bothersome. We started with an information session that I taught, kind of gave them the lowdown, much like I'm doing today, on some of the causes and some of the theories behind tinnitus, and taught them about tinnitus a little bit. We had them download an app called Insight Timer. It's a meditation app. It's just sort of one of the many meditation apps on the market today. Again, that's called Insight Timer. And basically said, what we'd like you to do is meditate for a half hour a day, 5 days a week, for 8 weeks. And during that time, we took some measurements. The Tinnitus Handicap Index and the tinnitus functional index are two very important tools that we as audiologists use to map how bothersome tinnitus is to our patients. And we saw some promising results. We saw that tinnitus handicap index scores after just 3 weeks were lower, which is an improvement, I should say. And similarly, tinnitus functional index scores were significantly lower. This isn't to say that meditation is for every tinnitus patient, and that we should forego medical evaluations or interventions. But when we think about how we can provide greater access, especially in this pandemic, these at-home interventions quickly became pretty exciting. So we published this back in the beginning of this year. So tinnitus is very complex, and I can't stress enough the importance of consulting with your physician, ENT, or audiology to be thoroughly evaluated. So the reason I talk about tinnitus quite often is because so many folks who enjoy music feel like their tinnitus kind of interferes with their music appreciation. And so quite often we're talking about hearing aids to improve their enjoyment of music, but also to help kind of manage maybe hearing loss and tinnitus. So kind of hopefully being effective in managing lots of different concerns for the individual in their lives. So we'll talk a little bit about these devices kind of in the context of music appreciation. So it's important to remember that hearing aids, bone-anchored implants, or BAHAs as they're sometimes referred to, and cochlear implants can all have limitations. So when we talk about pitch, let's think about our audiogram again. That's the highness or lowness of a sound. So whether it's the sound of a foghorn in the low end, or the sound of birds tweeting in the high end of frequencies, hearing aids can only both take in and put out, so input and output, so much of those frequencies. There's limits to that. We'll talk about that in a moment. There's limits on how loud a hearing aid can both take in sound, so the microphones, how much loudness of sound they can take in, and then also reproduce that to the listener, okay? One thing that all of these devices are good at is representing time. So when a sound reaches the microphones, it's delivered to your ear quite quickly. And that's important for music appreciation because we know that music is not just pitch, music is rhythm. And so it's very exciting to me when we think about kind of opening up our appreciation of music in terms of obviously pitch, loudness, but also rhythm. And so sometimes folks will ask me, well, does certain music translate better than others with these devices? And that is just so highly dependent on an individual's hearing loss, their use of the devices, the programming, and all those kinds of things. But I do have some general tips that we can talk about right now and kind of understand why these things work the way they do. So we'll talk about this briefly. When we have a hearing aid, we need to remember that it's limited by the loudness of sound that it can take in and the frequency range, the high pitch and the low pitch that we can represent. And so using a music program is the way to go. And we're going to learn about why that is in just a moment. So if we look at the image on the left, this is just meant to represent the loudness of a sound. If our hearing aid or hearing assistive device, whatever it might be, can take in the whole loudness that can represent all of this loudness, then we don't get any distortion in the hearing aid. Now, if our outside sounds are too loud, then we'll get kind of where it just kind of chops the loudness down to what it can actually handle. This is kind of a crude description of what happens with most listening devices, but it's still one that it does affect sound quality. And we'll talk about how to fix that in just a second. So we talked about the frequency range and the loudness. And there's lots of numbers and graphs here that tell us about what kinds of frequencies and loudness various hearing aids and manufacturers can handle. But I'll be honest, at the end of the day, as an audiologist, the device that I choose with the patient is going to depend on lots and lots and lots of different things. And so while it's important that we have devices that can represent sounds in a realistic way, I have yet to come across a hearing aid that I work with that there's much of a difference across the loudness that it can take in and the frequency range. And quite honestly, a lot of my patients just have personal preference. When they start with one manufacturer, they get used to that sound, their brain makes use of that sound, and they enjoy that sound. And when they come in and they say, hey, I want to try that other manufacturer, they end up not liking it because they're just so accustomed to making the most of their sound quality. Similarly with cochlear implants, there's limits to kind of the frequency range that can be represented in a cochlear implant. So we're seeing here in the highest sounds that we can still capture most of our speech frequencies. And similarly here in our lowest sounds, it does a fairly good job of representing a lot of our speech frequencies. But remember, like I said before, music and being able to hear some of the kind of higher frequency information may not always be represented by hearing aids. And again, if we look at our hearing aid example here, we're going out to about 8,000 hertz. So again, it does a great job of covering the speech frequencies, but we might be missing some finer detailed information of music. So the important takeaways to all of this is that we should work with our audiologist or hearing instrument specialist to meet our hearing needs based on our hearing levels. And sometimes we need to remember that, there are limitations to these devices. And we just described several of them. One of the biggest tips that I offer to folks who are trying to enjoy music more fully is that our hearing aids, like we said, are limited in the amount of sound they can take in, but quite often they can put out more sound. So what that means is if we turn up our stereo, our hearing aid may not even be able to handle the loudness of that music. But if we turn up our device, then it makes the most of the sound that's coming to the hearing aid and amplifying it based on your sort of prescriptive needs. And the last thing that I want to share with you all is that in many of these devices, there is what's referred to as a music program. And a music program, there's lots of kind of fancy things that happen behind the scenes to process sound, to optimize it for speech, right? Because that's really what us audiologists do the most of. We've been saying that all afternoon here, is that we're really trying to focus on speech. But these hearing aids and other assistive devices, sometimes when we're listening to music, they make some bad choices. So that's why there are specific programs for music. And so I want to encourage anyone who's interested in improving their music enjoyment to talk with their hearing care professional about possibly thinking about a music program. When we talk about music appreciation, it goes well beyond what hits our ears. And what strikes me about even being in your meeting prior to this presentation is that you all have found ways to make use of various technologies to help support you in your daily life. And so I kind of wanted to just point out some of those things when we talk about music appreciation. It's important to remember that listening with or without any assistive technology is always a reasonable thing to do. If that's the way that you feel you enjoy a listening experience, then that's valid. At the same time, and I'm sure you have all learned this through experience and through your discussions with each other and family and friends, is that quite often the more information we have, the more we can put things together for ourselves. And we'll talk about that in just a moment. But clearly, discussions of how we can stream directly to our various devices through Bluetooth or telecoil, using things like captioning obviously is quite helpful. And I think it's reasonable to apply some of that to our music listening too. One of the things that when I was studying music, folks would quite often come to me and say, boy, I wish I had a musical ear, or I really wish that I had that gift. And to be quite honest, I didn't always have the best quote unquote ear. I didn't always hear things the way that I needed to in my early training until I started learning how to listen. And so quite often with those with hearing loss, we talk about oral habilitation or rehabilitation. And sometimes that can be in the form of sitting with an SLP, a speech language pathologist, or an audiologist, and working through various activities and exercises. Now that's a formal version of oral rehabilitation or habilitation. But less formal is probably what many of you do, and kind of wearing your devices on a regular basis and living your life and kind of learning how to make use of your assistive devices. So it seems like a bit of a reach to ask folks to think about studying music to better understand and appreciate what they're listening to. But to be quite honest, that was one of them, a very transformative part of my training was not just being able to listen, but understand what I was listening to. And so, the possibility of, taking some music classes to understand music theory and harmony seems like it's out of reach, but really the more context clues we can get, the better off we may be. And we're in a very musical town here. So I think it's very reasonable to think about how we might enjoy music when we're given a little bit more information. Obviously, we've talked a little bit about some of the benefits of technology. We had alluded to the benefits of Zoom in the meeting previous. But here we are with an opportunity to appreciate music. And I want to just point out that when we go on YouTube and we want to look up a favorite performance, what we have here is something kind of delightful, and I think we shouldn't take it for granted that, sure, we've got subtitles. We can stream this information directly to a device if we choose. We can play it on our home stereo system in the way that we'd like to hear it. But we also have the actual action of what's happening on screen, right? So this seems obvious to those who, use this when they watch TV or those kinds of things, but actually it can also help our music understanding and appreciation too. Again, this seems kind of daunting to a lot of folks who are not trained in music, but one of my favorite things to do with my nieces is actually kind of fake read a music score. And this can also kind of support our listening. And when, like I said, when we learn a little bit more about, music and how music works and is put together, these kinds of things can also give us some context clues about what we're listening to and what we might expect. So, for example, we may not know what all those notes and rhythms are down in the very bottom 4 lines of music there. But when we hear the strings come in and we kind of follow those 4 lines and we hear those strings going, then we kind of start to expect what might happen. When we talk about giving the brain more information for our listening, I thought it quite interesting to share this with you all. Paul Bacchi-Rita was a researcher doing lots and lots of work with something called sensory substitution. So he did quite a bit of work in balance sensory substitution, basically trying to retrain the brain in people who lost their inner ear function to use tactile stimulation. So actually he added like a little electrode on the tongue, and when people would move around, the electrode would kind of provide a little bit of stimulation. This is all to say, this is not technology that's available to us to help with kind of sensory substitution, but it is to kind of remind us that the brain is very plastic. And so when we think about trying to provide stimulation to the brain, whether it's through our assistive listening devices or the information that comes to us on screen from reading or the action within a play, I just kind of find this kind of thing very interesting. They haven't done much of this sensory substitution with music perception, but the reason it hasn't gone very far is because quite often these devices can't really represent sound in a way that a lot of people can end up using. So, these are still some things that I think are very interesting. Maybe we'll see some advances in this in the future, but I just really present this in a way to kind of drive home the point that the more information that we can get, both in our speech and communication and our music listening, quite often the better. I covered lots and lots of things today. I'm sure there are lots of questions, but I will gladly open things up to folks and hopefully provide some clarification, because like I said, I covered a lot of ground today.
Brendon, this is Chaz. Can you please stop your sharing? Thank you.
So I have a question. I'll take a moment with it. The question is, can a repetitive machine/static oscillating sound heard at voiced speech level for hours at a time elicit a tinnitus response from a person's brain after hours, days, months, or years of exposure? That's a great question, and I appreciate that. Quite honestly, that's something that I can't answer because, to be quite honest, there's not a whole lot of information about those sound level exposures over time. So we do know that noise-induced hearing loss can certainly impact your risk for developing tinnitus, but it becomes quite difficult without a comprehensive evaluation to really see if that's what's the sole cause of tinnitus. I know that's not a great answer.
Say something.
Hello, I have a question. It's Laura. I was interested in your talking about the research, and I think, it was on meditation. What occurred to me is that the index, the handicap index and the functional index were self-reported, weren't they? There was no mechanism for evaluating that.
That's a great point. Yeah. So those, I'm sorry, is that your question or comment?
Well, there's a second part, but
Sure.
Go ahead.
So the tinnitus handicap inventory and the tinnitus functional index have been studied to be what we refer to as validated measures. So if we think about a pre and post measure of tinnitus bother, for example, we measure how bothersome that person reports their tinnitus, right, at the start. And there are tricks to this, and this is where the research gets very sticky, right? If we ask that person too much, right, if I ask them every day, how's your tinnitus bother? Well, that could influence them and go, oh yeah, I am bothered, right? So the goal with that was to stagger in some intervals. And actually a lot of the meditation literature suggests that the brain actually changes in some areas after 3 weeks. So that's why we selected that 3-week time point. We measured again at 3 weeks and then again at the end of the study. And again, a lot of the meditation literature recommends these 8-week programs. So that's a great question. Tinnitus is almost always self-reported. And so when patients come to us and say, my doctor diagnosed me with tinnitus, quite often what I say is, well, do you have ringing, rushing, roaring in your ears? Yes. And so that's really all we have to diagnose tinnitus.
Okay, the second part of that was, did you think about having what I would call a placebo group that had a fake meditation for that same amount of that same period?
That's a great question too. So this was what we refer to as a pilot study. And typically we would want to recruit a control group. You're right. A group to compare our findings, right? And since it was just a pilot study, we wanted to see, well, would people even do this thing? Would people even attend a session, do this meditation on their own? And actually, we learned a lot from that question alone, because we did have quite a few people drop out of the study. That's why I say this at-home meditation may not be for everybody, right? But at the end of the day, when we wrote this paper, we took other similar interventions. So we compared our intervention, which was go off on your own, do your 8-week sessions, 30 minutes a day, 5 days a week, and compared it to other interventions like cognitive behavioral therapy, okay, like mindfulness-based stress reduction, And so even when we use those other studies to compare, then we still see significant benefits. But I am certainly not here to say that this is the go-to, this is the one and only, because tinnitus is a very, very complex beast. Does that answer your question? Great. She is muted, but I'm seeing lots of affirmative nodding. And I see a hand raised from Bruce.
Hi. Okay. I got two-parter. One is my wife's tinnitus. She's had bad tinnitus most of her life, or at least since I've known her. And we've talked to every audiologist in town over the years. Finally, the one I go to, she read a report that says sometimes if you just take a hearing aid and just feed the sound through and don't do anything to it, just straight line through, it helps. So she says, no, you get 90 days to try it. So we'll order a pair. And so we got a pair of hearing aids, and she plugged them in with just about a flat line, setting. And she puts the hearing aids in, the tinnitus goes away. She takes the hearing aids out, the tinnitus comes back. Ever hear about that? It's
yeah. So, when it comes to specific questions about tinnitus, I always remind people every hearing loss is different, every brain is different. And so I always try to caution these kind of brushstroke statements. So for your wife, for example, that worked great for her. Essentially, when we talk about the causes and the mechanisms of tinnitus, quite often, we're not measuring every single little pitch in between the pitches, and there can be, hearing loss within those pitches, but we're also providing some kind of sound stimulation to the brain, and sometimes that can interrupt that, to use a fancy term, neural dyssynchrony that is known to be caused by tinnitus. That is typically not a first line intervention, but as you mentioned, your wife worked closely with her audiologist to say, we've tried a couple things here. Let's try something else. And that quite often is the road for many tinnitus patients, is finding the multitude of approaches that may help reduce tinnitus bother.
In my case, now my question for myself is, my tinnitus is a constant 4,000 hertz ring. And you do a hearing test, and when you get to 4,000 that they tested, they could turn it up all the way. And the tinnitus is masking the hearing test. So it gives you false results when they program the hearing aid. We always have to compensate for that, because I could really hear 4,000. It's just that I can't do it on the hearing test. And I always thought that'd be strange.
Yeah, again, it's not uncommon for folks to their tinnitus to be so specific to their hearing loss and hearing levels. So
yeah, that's been my experience.
I'm sorry. I encourage folks to use the chat.
My experience. So yeah.
To use the chat as well. They're able, because I can't quite see all of your lovely faces and the hand raised.
I have a question.
Yes,
My
Sue.
name is Sue Miller. About the program that you were talking about, the Insight Timer. Do you spell Insight C-I-T-E or S-I-G-H-T?
S-I-G-H-T.
Okay.
And there's 2 T's, Insight Timer. It's all one word.
Yes. Can you just tell us a little bit more? How do we get one of those? Is it something?
Oh,
it's an app?
It's an app, yeah. And basically, patients would ask me like, well, what should I listen to? Or how should I practice? Or those kinds of things. And to be quite honest, when it comes to meditation practice, there's lots of guided meditations. There's lots of kind of soundscape kind of meditations, music meditations, just lots and lots of different things. But remember, at the end of the day, we know, that tinnitus bother and anxiety can ramp up our tinnitus. So what we're trying to do is find that activity that you find both relaxing, stimulating, and those sorts of things. So if you do want to just try something like that, you know, that's how you would go about doing that. Just kind of trying out some different meditations. We gave participants no instructions on that front. We said, just enjoy yourself, do the time that's asked of you.
Well, I have another question for you too. This was so
Sure.
This was so interesting and so different. Such a different approach from what we've been listening to for so many, almost 40 years in our chapter. I'm wondering if you've ever considered giving this program or your presentation at a national convention.
I'm always
or
happy.
HLAA.
Sure, I'm always happy to give this talk, and you know, when I do, I always try to couch this in, firstly, the importance of medical intervention where appropriate, working with your professional closely, and never will you know, my talk or just one kind of intervention be the cure-all. But this is a relatively new area in tinnitus research. But what has attracted me so much to it as a provider is, firstly, that there are no side effects to meditation practice, except maybe a sore hip here and there from sitting too much, but there's lots of ways to meditate. No side effects. There's been countless other studies that it improves, you know, so much other functioning in terms of our emotions, but also physical function. They've done studies on low back pain and a whole lot of things. And so to me, this idea of access to healthcare, access to interventions that may be helpful is really what drew me to this. So hopefully we see more of this kind of research coming out in the near future.
Well, the next national convention is going to be in Tampa, Florida at the end of June. And if I send you the information, I don't know if it's too late for the call for papers, but this is definitely something that would be I just have a feeling that it would be extremely well attended.
I'm always happy to take some information.
Thank you. Thank you.
Yeah. I have a comment in the chat here, and it may be one of our last. Is musical tinnitus any more common among musicians or composers? There is something referred to as musical ear, or sometimes referred to as auditory hallucinations. I don't know that there's been any studies on the incidence and prevalence of sort of these, and if I'm understanding this correctly, basically tinnitus that sounds like music. I've had patients come in and say, I have this orchestral music just kind of coming and going all the time. Or I hear a man's voice singing, or I always hear 1940s dance band music. All of those things, right? I don't know that there's been any research to indicate that musicians, composers are more likely to experience those auditory hallucinations.
I have a question. Could I make
Yes.
one comment? I have a music program on my hearing aid, and I was curious, do a lot of people have music programs on their hearing aids? Because I love it. When I go to the RPO, if I turn it on and I get the full orchestra, and in church, maybe if I want to hear the organ play the full component of the range. But then if I go outside somewhere and I forget to turn it off, it's way too loud in general. I mean, it doesn't compress the sound. So I have to put it back down to my normal range. But I do find it very helpful. And I certainly enjoy the Rochester Philharmonic much more when I have it turned on. It is kind of loud, but you know, you hear everything. So I wondered if I'm putting a plug in for people. I don't know if everybody has this program or not, but I think it's a great program.
Yeah, I cannot encourage this enough because the processing that happens behind kind of behind the scenes really use the music program. If you learn nothing today, get a music program, use the music program.
Yes. I wanted to also thank you for being here today. I know it's 1 o'clock and I'm so happy that you could present to us. I think we have one more question. I don't know if there's time or not.
I can take one more question. Yes. I think Eric was.
Yeah, just a quickie. I know that tinnitus is top of the list on veterans complaints to the VA. I wondered to what extent there's a collaboration between the VA and the private sector on tinnitus.
Actually, the VA is responsible for one of the most cutting edge, what is referred to the tinnitus management program called progressive tinnitus management. It was developed out in at the Portland VA under a guy named Jim Henry. And that model is one of the models that sparked a lot of this sort of like realization that it's not just ears, that it's a more brain level thing, and sort of kind of creating workbooks and a whole program, sequential program that folks go through. So the VA has been really groundbreaking as a system in terms of how they treat and manage individuals with hearing loss. It has certainly informed much of, personally, my practice and many other tinnitus practitioners. And Dan, I saw a hand from you, and I'm happy to take that as well. No?
No, but we got like 1 minute left, and then we got to conclude. I'm thinking, Art, maybe you should go ahead and close up the meeting.
I was curious about the music program, but Barb answered my question. But I just want to make sure we remind everybody to fill out the evaluation forms for this session. It's an excellent session. Let's get it on the record as being so. And I want to thank Brendon myself. It's very informative. Just 2 other things that I forgot to mention. We're going to have an annual dinner on May 24th. So mark your calendar. And we're going to have a picnic on August 7th. So mark your calendar for that too. Of course, we'll have more information as time goes on. Thank you, Dan.
Charlie, you want to stop the recording?